Hello, everybody, and welcome back to Show and Tell Boston, where we facilitate those tough conversations that no one wants to have. My name is Cricket Smith. I have my friend Tata to the left of me. Say what's up, friend.
You.
That part. We have the director of Mass Seal here with us. He works in infectious diseases. He is a doctor at Boston Medical Center. He's an educator at Boston University. And he is now here with us at Show and Tell Boston. And his name is Dr. Ben Linas. Doctor, how are you today?
I'm great, thanks. Thanks for having me.
You are so welcome. Can you tell us a little bit about yourself and what you do?
Sure. So my name's Ben. Hi. And like you said, I'm a doctor. I'm an infectious diseases doctor. So I take care of people who are living with HIV infection. I treat people who have hepatitis C infection. I also work in the hospital sometimes when people have an infection in the hospital, like after a surgery or something like that, and we take care of that. A lot of my time I do epidemiology and health research, and so I'm a professor at BU, and so that's why we're here today, at least in part, to talk about some of that work that we're doing now, because one of the things that we really are interested in and want to try to improve upon is the way that we generate knowledge and the way that we develop new ideas in medicine so that we can be more engaged with our community, right? Instead of just showing up with our ideas and saying you should participate, to really engage with the community to think about the needs and to design interventions and projects that speak to community need, and then to partner together, right, to address the needs of the community. And we really believe that approach of engaging is what we need to do if we really want to get to justice and we really want to get to equity, right? Because we're not going to be able to take care of the problems of access that we have today by just throwing things from the outside on the problem. Like we got to engage with the folks that are actually living it.
That's right.
To hear about their lived expertise to really design better interventions and get the work done. So that's what Mass Seal is all about, right? It's the Community Engagement Alliance of the NIH, the community engagement piece. That's what's really driving our work and what's different about it than some more traditional research of the past.
Thank you for sharing.
And hear their needs to really start addressing some of the COVID disparities, right? So when SEAL first started back in 2021, it was about getting vaccines to people, getting tests to people, and getting treatments to people, all for COVID. And we did a lot of work on that in 2021, 2022. We did a lot of projects in the community. We helped BMC run vaccination pop-ups. We were in the parks working on tests and talking to people, handing out materials. And then as the pandemic sort of started to evolve and change, and then eventually they kind of wrapped it up, right? And they took away all the federal funding for the pandemic. So that was a big moment in the life of the Community Engagement Alliance, because up until then, the whole thing was being paid for by the pandemic response, right? It was like an emergency pandemic project. But I'll say this, for credit to the NIH and to the government. Like, they looked at this and said, this work is too important. The engagement piece is not about COVID. It's like the way we need to be changing our work and the direction we need to be moving in general. And health disparities COVID was just a really good example of them that made everyone talk about it, right? They weren't invented by COVID. And NIH saw that, right? And they said, we got to keep doing this work. So they actually pulled the project into like their normal regular operating budget, which is big deal, right? They had emergency money, so they added something on, but then they said, this is too important, we're going to keep it, and we'll figure it out, right? And they reallocated funds, and they made it something that they want to fund. And then more recently, right, the focus has changed a bit because I'll say COVID is still a thing. There's probably a COVID surge going on around us right today. A lot of people have COVID right this minute. But they want us to broaden our focus and to think more really about chronic health conditions and health disparities and equity. And so that's what we're doing. And our basic approach is that we're about engaging with the community, talking to folks, sharing our ideas and hearing their thoughts about that and what their needs are. And then together with members from our community, trying to come up with ideas for projects, for interventions that we can do with the community, in the community, to hopefully improve health. And so we have a variety of projects that we're running now that really are focused on engaging and on improving health outcomes, improving equity. And that's what we are. So it's really great to be here. It's a great opportunity to talk to folks.
Could Could I ask which focuses did the organization deem to be like super important, and why did you guys want to focus on those?
Yeah, that's a really great question because there's so many things we could be working on. So our project is located at Boston Medical Center, and Boston Medical Center, the big, the network is one of our big partners. And so we worked with them. BMC for the last, at least 2 years has really been engaged in like an honest and organic effort to just define some priorities and to extend the hospital outward into the community. Right back 10, 20 years ago, big hospitals like BMC, sort of the vision was, okay, well, we're here, and when people get really sick, they should come here, and we're going to take care of them. And partly through COVID, I think people have woken up and said, actually, no, we got to get out there and start working with people in the community so they don't ever have to come here, right? Like if we're just sitting here waiting, it's way too late. And we're not going to actually fix these disparities at the 11th hour, right? We can't wait until people are acutely ill and dying before we try to fix the disparity. And so the hospital has really blurred the lines of what a hospital can do and what healthcare looks like, to recognize that talking about how to prepare healthy food, that's healthcare. Thinking about housing access, that's healthcare. And we can be doing that work. And so we partner with BMC because they've been going through a process of trying to do this and identifying priorities. And so we sort of jumped onto that, right? We leaned into that process that BMC has been putting together instead of reinventing the wheel and doing our own thing, because BMC has been having community roundtables and talking to leaders and talking to folks on the street. And they had identified 3 priorities right now, not for all time, but in this moment, that are sort of 1, 2, and 3 on the list. Or I should say they're all co-equal, but one of them is controlling high blood pressure. People may have heard of, sometimes you'll hear it called hypertension. That's the medical word. High blood pressure is the more common word. Super common for people to have high blood pressure. In communities of color, it's actually more prevalent. There's even more of it than just on average across the entire population. And because of health disparities, not everyone knows they have high blood pressure. They haven't been checked. They haven't been to the doctor. And you never know. You don't feel it until you have a stroke, until you have a heart attack.
Could I
right?
ask
So,
why? Like, why is that usually kind of, sorry, cricket's hat's like in the way.
why more high blood pressure?
Yeah, why is that like mostly like in like, not I would say mostly, but like why is that super prevalent in
Yeah,
colored
sure.
communities?
It's like all things, it's complicated. It's a variety of things. One thing is that there's just health disparities, right? And people don't have access to care necessarily, and they haven't been screened, they haven't checked their blood pressure, and so they don't know to take action. They're not taking meds or anything like that. Some of it is also around disparities and sort of structural disparities and access to healthy foods and high salt foods and things like that. If you have a tendency towards high blood pressure and you're eating a lot of high salt diet because you're looking for inexpensive food and don't have access to good nutritious produce and things like that, it'll drive up your blood pressure. And a piece of it is probably actually related to ethnicity. Like there's some genetic causes of kidney disease that are just more prevalent amongst people of color and people of African descent. So your kidneys are a big part of managing your blood pressure. So some of it probably is related to just ethnicity and sort of historic, inherited traits. But a lot of it, there's nothing that's just that in this society, right? A lot of it's about access to care, who has it and who doesn't.
I was gonna say, do you think it's I know people of color pride themselves on seasoning their food. Do you think we're like over seasoning our food?
I don't know. I don't want to start coming up with grand theories of high blood pressure amongst communities of color. Maybe,
funny.
I'll say this: if you don't, my dad's actually a high blood pressure expert. If you don't have a tendency towards high blood pressure, you're not going to give yourself high blood pressure with too much salt. But if you have it in your mix, then if you're eating and seasoning your food with a lot of salt, it can drive up your blood pressure. So probably maybe some of it is that.
Yeah.
But it's like most things. It's really a combination of a lot of factors. But it's sort of it's just true. Like the sky is blue, and there's a lot of high blood pressure amongst communities of color, and so that's why it was a priority. Another one was out of control diabetes, right? Like diabetes is also a really common disease in America generally. And, there's disparities and inequities in who has access to care and who's getting screened for their diabetes. That one absolutely has to do with food access, because if you have diabetes, a lot of it is about your diet. And so if you can't get good diabetes appropriate foods and you're just looking for, inexpensive food in order to fill your caloric needs, that can drive up your blood sugar, right? And that's out of control diabetes over the course of 10 years or so will just devastate you. It'll give you a heart attack and a stroke. It can make you go blind. It can destroy your kidneys. It's really, if your blood sugar is too high for a long time, it's a major, major thing. And so that's why that's a priority. And so those are the two that we sort of picked up upon as things that we want to work with BMC. I'll say there's a third one for BMC, which is maternal and child health and mortality, because it is jaw-dropping. If you look at the statistics about like infant deaths and maternal deaths in Boston, in some neighborhoods, it's really, whenever I see the data, I just can't believe I'm looking at numbers from the United States of America in the 21st century, right? Like we've moved beyond the era where people should be dying during childbirth, right?
What do those numbers look like?
They're really high. I don't have the number off the top of my head, but I'll tell you this: like, if you think about the map where it's like dark red, where there's not a lot and not, it's in this neighborhood, right? It's in Mattapan and Dorchester and Roxbury, where it's just way, it's just so much higher, and it's really striking because that's a condition that theoretically shouldn't really be happening anymore. Right. So BMC has really partnered with a bunch of folks around town to try to address that in this neighborhood as well. And so we're right now working on the diabetes and the high blood pressure piece, but we're always working sort of with our partners across all kinds of health conditions, because more generally, we really want to be thinking about access to care and about equity, and really beyond that, like just listening to the community, hearing the needs, and trying to partner together to come up with solutions.
Can I ask you? So we're talking about disparities. What are like the disparities in resources, like right now, that MECL and BMC offer that people can take advantage of and like use in order to kind of combat these things?
Yeah, sure. So we're doing a variety of things. So two things: we're funded by the National Institutes of Health, which is a big, right? It's the country's preeminent biomedical research organization. So NIH has NIH has like a $40 billion budget every year. So I think they're the largest sort of research agency in the world. And they go the gamut, right? They're studying everything across all of healthcare. And a lot of it is like basic lab work and things like that, but not all of it. Some of it is what you think of as like beakers and test tubes and doing experiments in a lab, but a lot of it is public health research, and that's what we do. And so, but we do it in the spirit, right? It's research about, we want to design interventions or projects to get out there to improve something, right? To improve the number of people that are seeing their primary care doctor and getting screened for diabetes, for example. So we with our partners, design an intervention, we would say. So for example, one thing we're working on now is we plan to hire community health workers from the community and to be working with housing developments in the area, to then have those health workers work in the developments to help people link into primary care, right? Have you seen a doctor recently? And if not, we can help you get an appointment. We can navigate you to the appointment. We can answer your questions. If you have concerns, we can be there. And then we are going to do a project where we then sort of measure what happens after that, right? How many people? Track
data
it and see if it works. Right.
Right. It's the only way to know if it's working.
Yeah, right. And that's actually really hard, right? Because sometimes we work with partners who want to do the work, but like research is provocative, right? The R word is provocative. Sometimes in our meetings, I'm like, guys, like some of the work we're doing, maybe we should stop calling it research. I mean, it is research, but it's not give me your cells so I can check your DNA and then make a new drug in 10 years.
That's a big thing.
Right?
Everyone thinks that.
Yeah, right. That's important to talk about, right? But it's actually not what we're doing. We're developing ideas for like community health worker to improve outcomes. right? And then we're measuring what happens to see if it worked. So that's research, but it's, I think most people would recognize it's sort of in a different spirit than doing experiments. But we do, right? You're right. Ultimately, the only way to know if it works is to do it, and also really to compare it to some people who maybe didn't get that thing, right? That's called a control group in our language of research.
Yeah.
So, right, you can imagine that's hard to do, right? And we do things like, okay, well, we're going to come to this place first. We're going to do our intervention and work with you. And in this other place, we're not going to do it first, right? But we're still going to be measuring. So during that, say 6 months, half of you are getting it and half of you are getting this intervention and half of you are not. However, at the 6-month point, we're going to bring everybody in, right? And so everyone is eventually going to get this. We're not going to start saying half get it and half don't. It's just a question of when. But with a little bit of sort of thoughtfulness and with the timing, you can set it up so that there's periods where half are getting it and half are not. Because you do need to have the people who don't get it, right? Because otherwise you don't really know it was the thing you were doing. It could have been something else, right? And that you just never measured and never knew about. So that's actually talking about that is hard in the community, right? This idea of a comparison group is not intuitive and it feels wrong, right? But our point is always, right, but we don't actually know what we're doing works. We think it does. We hope it does.
Right.
We're confident that it's safe. We're not going to hurt anybody, but like it might not work. And so you don't know for sure that it's better off. And if it doesn't, maybe it was just a waste of your time, right? So it's not clear that you definitely want to be in this thing. Like that's a big part of research, understanding that like we hope it works, we think it will, we know it's safe, but we don't actually know it works. That's why we're doing the research, and there's an honest to God question about whether or not this thing will work. Because if we knew that it works, it wouldn't be ethical to start telling people not to get it, right? So that's really common in research designs, this idea of comparing back, but doesn't feel good all the time. So we talk a lot about that to build trust, try to build trust.
And some of these interventions were for, like, say, the diabetes and high blood pressure, or?
So one of them, so we're doing two, thank you for bringing me back to that. So one is for diabetes and high blood pressure, more general, getting people linked into care. And so this is one where it's one of these projects where there's like an intervention group and a control group, right? And we try to be thoughtful about who's getting it in the moment and who is not. So on a random Tuesday as we're doing it, it's not available to everybody in the world. But our vision for that is that then if it's working, what we want to then do is a place like BMC could scale it up, right? Like we're this community health worker sort of model that we've developed and that we've evaluated and that we can show you it works, right? You can now start hiring more folks like that to get out into more communities, right? And it's not research at that point, right? You're just doing it, but you're doing something that you know works, right? Which is important, right? We don't want to be using our money and the time, like we have not enough money and not enough people who care about these topics, right? We don't want to be wasting that time and that money doing things that don't work. We really want to be doing things that we know work. So that's one thing. Another thing we're doing is it's sort of more foundational or abstract than that. It's an intervention really to build trust in the community and amongst healthcare providers to be more trustworthy so that people of color coming to the doctor feel like they have empowered to express their needs and that their providers are going to act in a trustworthy manner, and because of that there'll be more trust and better outcomes. And so this is an intervention that really was totally conceived of and designed by our partner Everyday Boston. So Everyday Boston does a lot of work with storytelling, and they convene circles of people to share stories. And over the last couple of years, I've had the privilege of going to a few, and I mean, they're really powerful, very powerful. And they did work for a couple of years with us, holding these story circles and documenting what happened. And they did a really nice sort of like capstone event last year at the Bruce Boland building, where folks, like several of the people who had shared their stories came to talk on a panel, and there were posters and everyone came together, and it was really moving and really powerful. And it was like, afterward there was cheese and people were chatting, and like every single person was
cheese.
Got to have the cheese.
Always cheese. There's food, right? People chatting. And everyone was just like, we got to, like, this is the choir. Like, this is so amazing, but everyone in this room already knows this. Like, we got to get this out there and turn it into some sort of educational thing for healthcare providers in the community. So that's what they're doing now. They took that, like, general idea of sharing stories, built it into I mean, it's a curriculum for health professionals and for the community where they'll come together. We're designing the details now 3 or 4 times over the course of a whole year. And every time they come together for a few hours, they'll be sharing stories and going through, there's question prompts and exercises together. And, talking to Everyday Boston, their point is it's the act of getting a healthcare provider and the community member patients in a room together as colleagues and equals outside of like the doctor-patient thing, right?
Yeah.
Where there's a power dynamic, and to just talk to each other. Just that has a huge impact,
100%.
right? And then we're going to do that, and then what we're measuring from that is, well, the patient's sense of empowerment to talk to doctors, trust in their doctor, feelings about medicine and science, and the doctor's behaviors and their sort of skills in working across languages, working across cultures, and being trustworthy to build trust. So that's a second project. And then with our community engagement team, we're out generally in the community, going to events, bringing health materials. At one point, we were bringing COVID tests and COVID vaccines, and it was very concrete, like this is what we are bringing. We have ears to the ground and always want to hear from folks, like what would be useful services and materials, right, for us to bring to your community today. And because we can work across languages, we develop materials in multiple languages, and we do our best to develop materials that are appropriate for our community and really made with our community in mind, right? There's many, many materials available online, public health materials from the CDC, from the American Diabetes Association, the Heart Association, all of these professional groups. And they're good. They're factually accurate, right? They professional people and communications experts on how to make good health communications. So, but they don't speak directly to our community necessarily, right? So we do a lot of work to start with some of that material, but then tailor it to our community, be that by language or by the visuals or specific messages, things like that.
I love all of this. Wait, let me ask a question. You've been asking all the questions.
Okay. Because I'm really curious about this, because you kind of just spoke on this, especially with the CDC. So how does the NIH collaborate with the CDC or even the FDA to create, more positive public health results?
Yeah, that's a good question. There's a lot of people in the federal government that think a lot about this, right? So we're talking NIH and CDC, and you mentioned FDA. Yeah. There's other places too, even. There's the National Science Foundation. There are a variety of federal government entities and agencies that are focused on science and research. But just to make it a little bit easier, let's just do the 3, like NIH and CDC and the FDA. So I mentioned NIH, that's the National Institutes of Health. That is like the world's preeminent, largest, best-funded biomedical research agency. I said the budget last year was over $40 billion. And the vision for the NIH is that it's doing science and discovery, right? It's got started up in the 50s. So back in the day, it really was like laboratory science. We're going to discover DNA. We're going to discover, right, things like that. And it still is. Like there's a lot of that, right? So there's a lot of work on looking for cures for cancer or the cure for AIDS or an AIDS vaccine or, right, pick it, cure for diabetes across the board. But also they do more than just lab research. We're funded by the NIH, right? So they do public health research, right? But the NIH is all about research, right? So they want discovery. The discovery could be how to improve health equity, right? But it's still a discovery per se. And they do that kind of science. The CDC is the Centers for Disease Control and Prevention. In some ways, it's almost like the National Department of Public Health, right? There's there's the Boston Public Health Commission. That's our local one. There's Mass DPH. People probably heard of them, right? The CDC is almost like USDPH. It's not exactly, but pretty close, right? So the focus there is really about public health and about doing stuff to improve public health. They do research and evaluation as well a little bit, right? There's some overlap. It's not like it's a super bright line.
Yeah.
But for the most part, what the CDC is interested in is actually funding departments of public health to do stuff in the world or to fund, right? Sometimes I'm funded on some projects by the CDC, but their questions are around sort of how should we make a guideline that everyone in America should be tested for hepatitis C, right? That's something we worked on with the CDC, right? So they didn't develop the test for hepatitis C, but they're thinking about like what should the public health guidance be, who should get it, who should not, those sorts of questions. And then the FDA is the Food and Drug Administration. So they're like a regulatory body. They don't do any research or anything like that. What they do is they approve medicines and and technologies for use in America. So the fact that you can go to the CVS and buy a bottle of Advil and you know for sure it is Advil and it's not contaminated and it's safe, right? Like we shouldn't take that for granted because that's not always true in everywhere in the world. And that's the FDA's job, right? So if a drug company invents a new medicine, for example, they've got to do, it takes a decade or longer, right? It's on the drug company. They have chemists who come up with the pill. They do all this research to first show that if you give it to mice, right, the mice don't grow two heads. And and at some point they have to be like, it's now reasonable to say that we can put this into a human being and they're not going to, right, it's safe. But now we have to find out if it works. And that's a multi-step process. Eventually they bring all of that evidence to the FDA and they say, please approve this, right? And then the FDA has scientists and doctors and pharmacists who look at all the data and they can say like, go do this or that. We need more evidence. But at the end they say either yes or no, right? It's approved or it's not approved. So it's a slightly different, right? They're using some of the science that's out there, but the FDA is like a regulatory body. So I hope that helps, right? It's not just so people are curious, and there's some overlap there, right? That's why they think about it a lot because they're always trying to look at where they can partner without duplicating effort and that sort of thing. Yeah.
That makes sense.
That's good. So they are here working.
What's that?
They're out here working.
No, they are. That's the thing. Like people slam the federal government. If you actually get in there and work with those folks, like sometimes I go down to the CDC and sit with my friends there. Like they're amazing people.
Really?
They work really hard and they care a lot. Yeah.
Interesting.
Yeah. So it's like, and that's my point. I know the CDC. I never go down to anywhere else in the government, but I'm always thinking, gosh, the people I know who work at the CDC are like outstanding. And honestly, all of them could be making a lot more money doing something else.
Yeah.
Like they're there because they really care.
That's
Yeah.
awesome.
So it's hard to hear that get slammed if they
Yeah.
make a mistake or
'Cause-
people don't understand.
Yeah, because a lot of people, especially around us, think like maybe the people at the top are like these like super sinister scientists.
Right. Yeah. Yeah. No, I know. Right.
Yeah.
So no one, to my not like, I really don't think anyone there is sinister.
Yeah.
Right. And then it's more complicated than that. Right. I'm not trying to say the CDC always does the best thing, but it's not as if it's because there's someone at the top twirling their mustache looking for how they can get
Twirling the
rich,
mustache,
right?
like, let's give it to the blacks. Yeah.
Yeah. Exactly. Exactly. That's not happening.
Another question I find particularly interesting is what futuristic science concept would you like to see come through the NIH research? From NIH research?
I'm thinking for a minute. Well, so I think that real, not just like sci-fi. I think a big focus right now across all of medicine at the NIH everywhere is trying to tailor treatments for diseases to the person. So if you think about it, right now we say, oh, you have whatever disease X. Right? That's a big part of medicine. Like a lot of medicine is trying to figure it all out and then put the thing into the diagnostic category, right? Because then you know what to do. Right. If you have X, I do Y. Right. And when it gets hard is when the person doesn't fit into a good category and no one knows what to do. So that's good. Like we do want to be able to have a sense of what to do, right, based on what you have. But then also, right, not everyone who has a certain type of cancer, for example, they're not all identical. Right. Like they're similar. But right, if you keep looking as we get more and more ability to look at like the molecular level and the genes of the tumor, right, we start to realize like, yeah, you guys both have lung cancer, but like this tumor does not look like that tumor. They're very different, right? From the outside, they're both just cancer, but from looking closely, they're different. So trying to think about, could we actually tailor the treatments that you get specifically to your version of this disease is like, that's like tailored medicine. That's kind of like the holy grail of what people hope that we can do. I will point out, like, that's why, right, if you like that vision, part of what it takes to get there is getting enough information into the database, right? Enough genetic information about people's tumors or whatever, right? Whatever it is that we're talking about from enough diverse populations that we can start to do that. And the problem is right now, especially amongst like repositories of genetic information, they're overwhelmingly white Western European descent.
yeah.
Like
Okay,
90%.
Y'all got to move up out of there. We got some real research to perform.
Right? But the
Yes.
thing is, like,
Yeah.
it's also hard because that's exactly what people are nervous about, understandably, because there's a not nice history around genetics and
Yeah.
stealing material. And, oh, we took those cells from
was
your
it?
mom
The
30 years
Henrietta-
ago and then
Henrietta
made $10
Lacks?
billion.
Yeah.
And
Henrietta
lost
Lacks
cells,
situation?
exactly.
Yeah.
That happened. That's real. So I get it. And if we want to get to a spot where these sort of futuristic sci-fi things are available to everybody, we need the information, right? So it's not, I want to be clear, it's on the scientists and the medical community to be trustworthy, right? It's not on the community to like sacrifice.
Yeah.
It's on the scientists to do better, right? And that's part of what Maciel wants to think about. Like, how do we talk about that?
Right.
Like, how can we do that in a way that's productive and that
Right.
moves us forward, that recognizes the problems of the past
Right.
and avoids them going forward in the future.
Yeah.
So I think that's one vision I have. And then I was saying, I think the other, like more sci-fi, I don't know, do you guys ever watch Star Trek?
I'm
watched it a few
screaming.
Like in Star Trek, they have this thing and they put it on your neck and it goes psh, and then like the person sits, like gets
Oh
better.
yeah.
So that idea that you could administer medicines across somebody's skin, that's actually not super sci-fi. Like that's a real thing. People
Yeah,
are
yeah.
trying to do that. This
Right,
idea
right.
that like, right, so there is maybe a future where we don't have IVs anymore. They right in, it just
That would
goes
be
in.
amazing.
But we're not there yet.
Going into sci-fi, this is a random question, but like, as a infectious disease specialist,
Yeah.
how do you think we would have fared in a zombie apocalypse?
Well, based on how we did with COVID, not very well.
Come
I'm
on.
not so sure that we get it together to combat the zombies all together and fast enough
Not come back to
without fighting with each other and
Right.
claiming it's all fake news.
Right. That is so very true.
100%.
Before we go to our break, what or how does the NIH's work translate into tangible benefits for public health and, like you said, like patient care? Because as you
Yeah.
were talking, I was like, maybe these doctors need to see like either like maybe they should have like mandatory therapy or, because
We all
I've
should
been
have
to some
mandatory
doctors
therapy.
who are so compassionate, and I've been to some doctors that are like, yeah, it's a brain thing. All right, let's go
Yeah.
make like
Yeah.
leave.
Yeah. Well, I feel like there's two things in there, right? One about like how NIH findings like impact health and how they have impact on people, and another run around like doctor sort of approach and
Yeah.
right, skills. So on the first one, on the NIH thing, I mean, honestly, it's probably a slight overstatement, but almost any healthcare thing that you've done, from Tylenol up through like advanced chemotherapy for a tumor, at some level, some of the science that underlies that was originally funded by the NIH.
Okay.
So often what happens is the NIH research discovers like the really fundamental basic pathways, right? Like, oh, this signal is elevated in people who have rheumatoid arthritis, right? This chemical. And they, right, all the science just show like if it's high, you get arthritis, and if we take it away, the arthritis gets better, and all of that kind of work is funded by the NIH. At some point then, in our system, when it's time to turn that into an actual like pill or therapy that a person can take, that's actually in the private sector, right? That's what pharmaceutical companies do. So they take the knowledge, that basic knowledge that was developed by all of the scientists across society and funded by NIH, and some of that basic science is also funded by pharmaceutical industry. But they take that and then say, now we're making a treatment. Right, and so we get it. We need to block that, right, from the science. We know we need to block that marker in order to help the arthritis. How are we going to do that? They have chemists that say, oh, we could design a compound that looks like this, and it would fit right there, and that might block it, right? And they do that. They have manufacturing people, right? Once you're talking about medicine, you got to be able to make it, right? You got to be able to make millions of pills, and they have to be sterile, and they have to be safe, right? Like that's a big thing. And they do all that work to develop the medicine and then to trial the medicine and all that stuff. And then, right, but at the end of the day, and then it gets approved by the FDA, like we were saying. And then it's a medicine and it helps people with their arthritis. But at the ground, right, underneath it all was some of that NIH-funded science. And that's really the vision. Like the NIH wants to be generating knowledge, right, so that everyone out there can use that knowledge to start improving health, right, through new treatments or new programs and things like that. And then you were also asking about non-compassionate like doctor communication.
Because
will
doctors
say-
have a lot of ego. I ain't gonna lie.
Yeah.
Some of them, especially the ones that are like entering residency, like the fresh new
Yeah, right.
doctors.
They're excited to be new doctors.
Exactly. Which I get, but yeah.
Right, no, fair enough.
Right.
Yeah, no, I agree. Well, so I will say this, like NIH even funds research about this, but that's us.
That's what I was
right?
going to
Like,
ask.
yeah.
That's
It's
my
getting a
next
little
question.
meta, but
Yes,
like,
yes.
right? Like they think that's research too. It's not
Right.
like we've been talking a lot about the lab, but like my lab is actually an office. Like I don't do test tube research. We do stuff about health policy and health economics. I work with Masil. And that's all funded by the NIH, right? So they do research about how do you train doctors to be better doctors, and how do you, right? And that's what it's going to take. So that's actually part of what our storytelling intervention that I mentioned is. It's like, how do you train doctors and healthcare providers, not just doctors? It's really everyone, right? From the front desk person all the way through.
Oh my gosh, yes.
How do you train people to be trustworthy and to act like a human being, right? And
right, while still being professional too.
yeah, exactly. I mean, it's hard, right?
It
Because
is.
if you can't,
I can imagine.
you don't want your doctor to break down in tears every time like they're sharing hard news with you, like,
Right.
oh my God, you're gonna die. I can't take this. Right? That
Right.
would not be constructive.
Right.
No one wants that from their physician. But at the same time, you don't want to like bad news, right? And I'm out of here. So, right, how do you like do those things is really, really hard. But it's about training. It's about talking to people and having compassion and hearing and seeing the impacts of the things that you do or don't do with your patients. And in a typical healthcare encounter, you don't get the opportunity to see the impact, right? Like you don't know what happened 20 minutes later when you left
Right.
the room. So that's some of the stuff we're trying to think about with MassSeal, like really trying to measure those things and show like you can really improve the way that doctors talk with their patients by doing this work.
Could I ask about the feasibility of that? Of like, you know, doctors and nurses and all the other healthcare providers have like say like a series of patients, and maybe like you don't have time if this person looked on WebMD and he's going to argue about what he thinks his like thing is, and you're the professional, you know, and you only have a certain amount of time to be efficient and get those done. You know, how could you, you know, implement like, okay, we want you to have conversations with people, but you have like a lineup of everyone needs to get seen.
Yeah, so that's definitely 100% true. The time pressure on clinicians is definitely pulling against the idea of good communication. It's not impossible, but it obviously makes it harder. And those pressures go up and up and up, right? Because the more, you know, the pace with which physicians see patients translates into how many bills get submitted, right? And so hospitals care about that, right? Like even a place like BMC has to try to stay in the black as much as it can, right? It can't just hemorrhage cash everywhere and go broke, or that we wouldn't have a hospital. But it's not impossible. And there's actually like people, NIH funds this research too, like thinking about this, like how do you do that? What are the like concrete skills that you can bring into your encounter with the patient, right, that are realistic, even though I only have 20 minutes, right? What are things that, what are approaches that one can take about setting expectations, about letting the patient, for example, say, these are, right, we have 20 minutes, so what do you want to talk about today? Right? And the patient might list 15 things. Like, okay, we're not going to get to 15 in 20 minutes. Pick 2. What are the most important? And then we'll see each other again in 2 weeks. Things like that. Right? And then there's a balance to be had. It's like, well, you might want to talk about whatever, but I kind of like to talk about the fact that your blood sugar is way out of control, right? And so let's make a compromise here. Things like that, right? You're right. Like the time constraint is real. And it does put some barriers on the communications piece, but it's not impossible. That shouldn't be used as an excuse.
Wow. Everything that you're talking about is everything that I love. Because I'm a beauty girl, but health and beauty go hand in hand, right?
That's true,
Like they go
100%.
hand in hand. And as me and Shane were talking about earlier, like health comes, like beauty, true beauty comes like from the inside out. Like what you're putting in your body, what you're consuming with your eyes, what you're consuming with your air. You know, even some places that you go, the air is more toxic than other places.
That's definitely true.
But it's important to bring, you know, this conversation to light, because health affects everybody. If you're breathing, then you know you have to be taking preventative measures, because sometimes you go to the hospital, it's already too late. So that's why I know that conversations like this is important. I know that it's valuable, and we're happy to have you here to talk about it.
Yeah, thanks for having me.
You're welcome. And so let's take a break. We'll come back and we'll talk more about you as a human being.
Sounds good.
Let's do it. All right, break. What's up, everybody, and welcome back to our episode of Show and Tell, where we facilitate all those tough conversations that no one wants to have. This is our part 2 of our episode, and we have Dr. Ben Linas with us, and we're going to get into a little bit about his role in Boston Medical Center, his role as an infectious disease doctor, and him as a humanitarian and as a person. So, my first question is, when you get to work, what do? What's the first thing that you do?
Get a cup of coffee.
Come on now.
But no, I mean, I think that's what I love about my job, actually. Like, I can't answer that. Every day is a little bit different. There's all kinds of different things that I do. So some days I'm working in my research group, and we do a lot of work around, a lot of my work is around the substance use disorder epidemic and the overdose epidemic and infectious diseases. And so we do like data type work and health economics and health policy. So some days I walk in and we're doing nitty gritty like math stuff and like doing data analytic kind of things, and I like that. But then other days I'm teaching, or some days I get to go to Mass DPH and talk with my colleagues there, thinking about what the guidelines or policy or interventions that DPH is doing. I get to do things like this, right, and come out and talk to the community. So really, it's like one thing that I love about my job is that it's not a routine, right? Sometimes that's stressful, but also it's like every day is a little different, and that keeps it fresh and fun. And I also have the incredible privilege of just working with really, really smart, passionate, dedicated people. A lot of them are younger than me, which is refreshing, and there's just a lot of energy. And there are many days if I come into work carrying whatever I'm carrying from home, we're actually like coming into my workspace with those people is very refreshing and therapeutic for me, and helps me to set aside my own stuff just because the people I work with are so inspirational. So I'm really fortunate that way. I love my job.
That's a beautiful answer. Thank you for saying
Thanks.
that. You want-
I'm sorry. No, I'm sorry. I want to go into these questions. We're gonna cut this out. Don't mind this. What opportunities does the NIH offer for training and education in biomedical research and public health?
Yeah, because can I say something?
Yeah.
Because we were just talking about, school and everything like that. And Boston is one of the most resourceful cities ever, especially as it relates to education.
Sure, yeah.
Right? And I saw that the NIH, if you participate in certain programs, they will pay for you to go to school. They will pay
100.
for your nursing.
Yep.
So can you tell us a little bit more about that?
Yeah, I don't know that program that you're mentioning specifically, so I don't want to start giving people advice, like actual concrete advice on what programs to go for. I'm happy to think about it with you. I just can't do it live on the mic. But they do more generally. NIH does a lot of training of careers, and starting, traditionally always they have done things like fund postdoctoral researchers to get their first grant, right, and get started in an academic career. And they continue to do that. I run a grant, it's called a training grant, where it's specifically designed. It pays the salaries of junior researchers so that they can gain skills and start to do their research and then eventually write their own grants and become, independent investigator where they're writing grants and paying for their own science.
Oh, I see.
But
Okay.
over time, and as part of the, new energy and mission towards equity, everyone recognizes that workforce development is critical, right? At a lot of levels. First, right, we need to have a more diverse and inclusive workforce so that when people walk into healthcare environments, they feel like they see some folks that look like them, maybe sound like them, or have something in common, right? Like that's important for all of us.
Yeah.
And there's great careers. I mean, this is the biggest economy in the world, and the biggest sector in our economy is healthcare. Right? There are a lot of jobs out there, and a lot of them are good ones, especially jobs in research. Right? These are careers that offer, growth over your career, where your responsibilities will grow as your skills grow, and autonomy to make decisions, and as you grow, like the opportunity to work with and maybe manage a team, and to see sort of your product grow over time, and benefits, all of those things. Like these are good jobs that a person can grow in for, they're not jobs, they're careers. And really, a lot of people don't even know that they exist, right? And so the NIH has been doing more and more work to get like sort of younger and younger, right, funding high school age programs and undergraduate college programs to really open people's eyes to this workforce and the needs that we have. And it's really important. Like, I think this is one of those ones where everyone wins. Like, again, these are great jobs, potentially great jobs. And we need it so desperately in the research workforce. Like, we've done a lot of work with this at BMC and talked to a lot of patients who were thinking about maybe being in a clinical trial for COVID or for something else.
Yeah.
And some do, and a lot don't. And we try to talk to everyone. We do research about this to understand why and why not. Yeah. And one thing that's really important that helps people feel comfortable and want to participate is, right, seeing people on the work team that sound and look like me. Right. And it doesn't have to be a perfect match, but right, like, we want to have an inclusive team, and we'd like to have more than one language skill on our team.
100%.
And that's not always easy, right? We got to recruit folks and train them up, but we all win, right? The research will be so much better. It'll be so much more comfortable for patients and for participants, and it's great opportunity for job and career growth. So, and NIH funds all of that work, a lot of that work. So, it's not just the science. It's also building up the platform, right? That infrastructure, so that we have people that want to do the science. All of that is in the mission of the NIH.
Speaking of that, talking about how big the NIH is, like, how much does the NIH have in, like, shaping, like, public policy, and then also with policymakers?
Right. So that's an interesting question. And so the NIH, by sort of law, no one from the NIH, nor is anyone paid by the NIH like me when I'm talking with my NIH hat on, allowed to actually do lobbying work for an actual piece of legislation, right? So you can't walk in and say, bill whatever, right? Right, because that's not the NIH's role, right? It's not a political organization, it's a scientific one, right? We can debate, right? Is there really such a thing as science without politics? Probably not, but it's certainly not a blue-red lobbying thing, right? Definitely, right, it's okay to talk about ideas based on data, right?
Yeah.
So the idea that we need to be expanding access to care, that's political in the sense that, like, politics is about, right, the way we structure our society and the way we prioritize our resources, and those sorts of decisions are like small p politics. So absolutely, that's part of what we do, right? All the work that I do around substance use disorders, we have thoughts about what good guidance might look like, right? And we will talk about that all the time. We'll talk to DPH. We'll go on social media. We write articles. But we don't say, oh, House Bill 207, you should vote yes, right? That's not okay. But it's the science that the NIH is funding is informing political decisions, like the small p kind of politics and public health decisions. And it's a big part of the evidence base that we use to make good policy.
Could you kind of go into, like, the tangible, like, work that the NIH does that gives, like, to the public benefits?
Well, I think that so they have two versions of what they do, actually. One is what they call their extramural program. So outside, NIH has an actual campus in Bethesda, Maryland.
Oh.
Right? And maybe I'll start with that. That's called intramural, like on their own campus. So there are scientists who work for the NIH. Like, they live in Maryland. They wake up every morning. They go to the NIH campus. Their lab is there. Right? There's clinical trials going on there. So they fund, part of their budget goes towards that. But then a lot of their budget goes outward, right? It's this vision of, like, oh, we want to plant 1 million seeds, right? We're going to crowdsource this one because there's a lot of smart people and a lot of big universities and great colleges in America. And so we're going to spread it out there. We'll put out grant opportunities. Everyone's going to pitch us their proposals, and then we're going to fund the best ones, right? With the idea that the cream will rise. So that's the most, I think, concrete thing that they do is pour tens of millions and billions of dollars into our economy and into the healthcare sector to fund research from people like me. And sometimes it's very abstract. Like, you can always, in fact, there's always the opportunity of just to say to the NIH, this is my idea, you want to fund it. Like you don't, right? And then also they come out with opportunities like we're looking for X, Y, or Z, right? Programs about this and programs about that. So they get a little more concrete in terms of like requesting specific things. But really, a big part of what they do is fund the work, right? And some of the grants also fund opportunities for scientists to get together and share their ideas and come up with new ideas, right? It's that sort of like, putting the ingredients together, right, to let everyone else start doing the cooking.
Could you like tell us like what exactly after they funded the research? What are some specific things that were like a benefit for the public after that research was funded?
Oh, I see what you're saying. Well, so for example, COVID vaccine, right? Like the vaccines themselves come from drug companies that we all know. But the concept of the mRNA vaccine was originally funded by NIH research, right? The fact that you can just do this, that you can do these mRNA things and like do that whole process, that comes from NIH-funded research, right? And then pharmaceutical industry, once that's known, starts to think about, oh, well, how could we apply that to actually make a vaccine? Because that's a different question. We talked about that a little. You have to think about things like manufacturing and distribution, right? NIH doesn't think about that. But the COVID vaccine absolutely stands on the shoulders of NIH-grounded research. All of the treatments for HIV, right? Like it's drug companies that make the treatments. But the initial chemistry, right, of how this might work, that was a big deal, and that was funded by the NIH. Like those medicines for HIV were the first example, believe it or not, of a medicine where we sort of knew what was happening at the molecular level and designed a medicine to stop it. Up until then, what it was drug companies have these, they still do, have these huge like medicine chests filled with like stuff, like bits of plants and compounds and chemicals and things that might have some therapeutic potential. And then if something happens, they used to just sort of try it out and see if it works, right? And they would just try a gajillion things and hopefully something works. And if it does, then we go forward with that and see if it becomes a medicine. It wasn't until actually like the 80s and 90s with HIV that they were able to say, oh, this is how the virus packages itself up and how it does its thing, right? And if I designed a small molecule or chemical that fits in this little spot right there, right, it would block it and stop it. And so then they designed that thing and it worked. That was all, like the medicines don't come from the NIH, but that concept and the proof that it works and how you do that, that's funded by NIH dollars. So really, almost everything that we call healthcare at some level, if you pull the thread and look at the knowledge that grounds it, at some point it was likely funded by the NIH, at least in part. So
basically everything,
Yeah, I mean, it's really, really critical, and that's why it's so big, and that's why it's still there.
No, that makes sense.
And it's also why it's important for us to be talking about this.
Yeah, absolutely, because people don't, I mean, not everyone knows about the NIH. It got a little more famous during COVID. But honestly, like, that's a hard way to get famous, right? Like, right? And it wasn't necessarily all good, right? I don't know. It was good publicity. Some people say no publicity is bad publicity, but, there was a lot of mistrust and stuff because it is sort of like in the background on everyday life, but actually it's having huge impact on almost everything we do every day in healthcare, at least.
Speaking of epidemiology and infectious diseases, like what was your catalyst for deciding to work in this specific specialty of medicine?
Yeah, that's, it came from, it's a great question. I mean, I could tell you the story, which is that.
Yes, please.
I was in medical school. My wife, who was not then my wife, but we were living together, was in law school. And she was a public interest law student, so she had a scholarship to do public interest law. So the summer after your first year of law school is the summer where most students go and work at a law firm, and they get wined and dined and recruited to work at these law firms. But her program had funding to then go do some sort of public interest project for the summer. And so she actually got recruited really heavily by an organization that's called today it's called the Drug Policy Alliance. And this is like 97. I'm dating myself.
Nice.
So it's the very beginnings, if you think back, of medical cannabis in California. And they were thinking like legally about like the legal case that they needed to make for medical cannabis. And so she was out there actually working with them, doing sort of the legal work. And she was like, but I have this boyfriend. And they're like, oh, we'll find him something. So they found me a job working at this place called the Trauma Foundation at San Francisco General Hospital, which for the most part thinks about motor vehicle accidents, helmet loss, seatbelt trauma, right? Accidents and trauma and injury. But actually, if you look at the CDC, like overdoses and poisonings are categorized as a trauma or an accident.
Oh, really?
And so, so the same people that think about seatbelt laws actually are the part of the CDC that thinks about overdose. There's more than one part.
Fascinating.
That's a little bit of an overstatement, but the like poisoning stuff is in the same area as traumas. And so this group, at this Trauma Foundation group, they were really actually kind of prescient, I think. Like they were way out ahead because they had me working on stuff looking at rates of overdose amongst men in urban centers at that point, and showing that like actually it's like a number one killer of men aged 24 to 35 in a lot of urban centers, like more than motor vehicle accidents, more than, right? And that predates by like 20 years what we're going through now. And I was looking at things like HIV transmission amongst people who inject drugs. And that was, that caught my attention because really it's also an issue of equity and justice, and access to care and marginalization of stigmatized people. And those things make me angry, like, right? Sort of like ignite my own sense of righteousness. And so I was like, this is important. And I also, you know, you might be able to tell from everything I've been saying, I'm really interested in sort of social sciences and economics and policy, honestly, more so really than like DNA and like traditional like medicine, you know, science. And that's the HIV piece is that, right? HIV, the history of HIV and HIV public health is really social medicine, and it is politics, right? It's about like who's marginalized and stigmatized, and so this disease is allowed to spread, who's getting services, how do we reach these very difficult to reach and marginalized populations or communities, I should say. And that's the work that really compels me, more than the molecular mechanism of how the HIV meds work. It's the like, how do we get out there and talk to people and deliver care? So that I was like, oh, this is sort of all the things I'm interested in. And so that's when I came back and I started working at a syringe service program in Manhattan, thinking about HIV and thinking about hepatitis. And like, I still do that to this day. My wife is no longer a lawyer. Well, she's an advocate. She does still do legal stuff, right? She's an intimate partner violence advocate. So she uses her legal knowledge. So that's how I first got into it. And then I sort of came back to med school and started building a career in that direction.
Nice. So what are some more things that kind of like either make you passionate about like in this field or like or grinds your gears? Is it misinformation? Like what
that'll grind a gear for sure. I think one amazing thing, right? Both things. Both when I'm being a doctor, sitting with patients, but also when I'm doing things like this or working in the community. Like the job gives me like a remarkable. Like it's really a privilege to be sitting there with people. It's a privilege and a duty. It can be hard. But often when you're being a physician, like you're in the room with someone who, let's be real, they're a relative stranger to you, right? Like maybe I've known you, I saw you in the hospital and we've known each other for 4 days. And here I am with you and your family, like helping you think about some of the hardest decisions of your life, right? Like that's compelling, right? It's hard. I don't always like it, right? Like, right? It doesn't always go well. But when it does, like, it's really like, it's a pretty privileged spot that not a lot of careers can provide, right? Like, there's not that many careers that put you in that position sort of on a routine basis. And it's the same, like in some of these conversations with community, when it goes well, right? It's really an opportunity to be in places and hear stories that otherwise I would never in a million years have the opportunity. So, and I've had cool opportunities over my career. I've lived in Argentina for a year and I was doing stuff around after medical school and before I came back from my training. And I was doing stuff around HIV prevention. And I was also doing syringe services. And the group I was working with had a model where they were delivering materials to a house that later in the day would become a place where a lot of people were convening to use drugs. But at like 4:35 in the afternoon, it was a little more chill. And like we would just hang out there, like drink some beers and I was like, there is no way in a million years I'm ever going to be in this like basically shack outside of Buenos Aires.
Trap house. That was at a trap house. That was at a trap house.
That's what it. Yeah, I mean that's what it. And right, and it was so like, how do you get to do that? Like this career has given me a lot of opportunities like that. So that's what I love.
That is crazy.
Could I ask too?
It's fascinating. No, for real. Delivering resources like that, but like that's
No, we would deliver clean syringes
like,
and stuff
right.
about HIV and like
some people might not be ready to, some people
100.
might not be ready to get off of drugs, but they want, they
Yeah,
don't
well,
want to.
that's called harm reduction, right? That's the idea. It's like,
Right, okay.
like some people can't, some people won't. You're
Right.
not ready. We're going to meet you where you are
Right,
because
right.
we want you to be healthy. And by the way, one day, if you decide that you are ready, we'd like you to be alive.
That's right. That's
Right. And so no one gets better from anything if they overdose and die.
Come on.
Right. And no one wants to have HIV infection. And like, we're not like, so that's the whole idea of harm reduction, right? Meet people where they are, get them the services they need now to be healthy as they can, right, to be healthy.
That's right.
And that, right, in the world of drug use, like being healthy doesn't have to mean they're 100% abstinent in all moments, right? It's possible to right, we're all using substances of some sort, right? I just said the first thing I do is get a cup of coffee.
Yeah.
Right, a cup of coffee is not as dangerous as injecting heroin.
Right.
But point being, right,
on the
we're not
spectrum.
we're all
Very
using
different.
some substances in different ways, right? And we're not gonna start belittling people or thinking they're less of a human being
That's right.
because of their substance use, right? We're gonna work to get you what you need and help you be healthy. So that's what we were doing in Argentina, and I mean, it was sort of crazy, right? It's like this. There were times I was like, I just can't believe I'm here, right? And I had a funny time where, like, right at the end, where I had to go home and I wanted to take pictures of my friends down there. So, all right, this also dates me because it was still the 90s. Actually, it was 2000 at that point.
Yeah.
But we still had film cameras.
Okay.
Right? So I didn't have, like, there was no iPhone. The iPhone was still like 8 years away. And I had like a little camera, but like, right, I took it out and it was like, you might have thought that I took out, like, right, it was like a Star Trek thing. Like, it was this tiny little camera that I got, right, and I was like, look at that camera, right, like it was, so it was a cool experience, definitely.
Heck yeah.
If you could eradicate one infectious disease, which one would it be?
I think definitely tuberculosis.
Really?
Just because it's like a leading global health across the world. It's a leading infectious killer of people. There is a lot.
People still get tuberculosis?
Oh yeah.
That is crazy.
Oh, absolutely. It's a huge public health problem. Certainly in East Asia and in Sub-Saharan Africa and in parts of Central America, like in Peru and Haiti, but in the United States too. And it's another example of one of those diseases, like people don't get tuberculosis at random, right? So even in the places where there's a ton of tuberculosis, like in South Africa, for example, there's a lot of tuberculosis, and there are people of means who get tuberculosis because there's so much of it out there. But you can imagine, where's the burden of tuberculosis? It's in the shanty towns where it's overcrowded and there's no health care, et cetera. It's not it's not as much in the wealthy suburbs where there's gates and communities. And same thing in America. There is tuberculosis in America. And a lot of the tuberculosis we have in the United States is folks who have emigrated to the United States from countries where there's a lot of tuberculosis. But there's also tuberculosis that's just good old-fashioned in America, transmitted from one person in America to another person in America. But again, where does that happen? It's in homeless shelters. It's in correctional settings, right? It's on the margins of our society where people get stigmatized and forgotten about. So a lot of infectious diseases is like about justice and equity, right? Because not all of it, right? Anyone can get a bacterial infection after they have surgery. But there's a lot of infections in the community that roll with poverty and with being marginalized. And so that's part of what compels me to do infectious diseases. And what I like about my job too, because that's largely what compels almost everybody. Like, I don't want to be too totalizing, but almost everybody in infectious diseases has a focus on that, because I'll tell you, it's not the best paid specialty amongst doctors, right? Like, if you wanted to make more money, you definitely should not do infectious diseases. I'm not.
What should you do?
I'm not crying. I'm comfortable. It's great, but like if you should be some sort of subspecialty surgeon, right? The way our healthcare system works, anything you do that's procedural, like if I do something, even if it's just like take a biopsy of your skin. Those things get reimbursed and paid for a lot more than sitting down with patients and talking for an hour and writing a prescription. So, in any event, that's fine. But the nice thing about it is that's who does infectious diseases. It's people who are interested in global health and epidemiology and justice and distributing care and taking care of the marginalized. It's so which makes my job great every day.
Can I ask if there was another, say, like, global epidemic,
There will be eventually, right? It's
Yeah, I mean, I think we're kind of counting on it, honestly.
Yeah.
How do you think that would go? Like, do you think because the COVID vaccines came out relatively fast?
that was amazing, actually.
Do you think the other ones will come? In the future when it will come out faster? Do you think misinformation will be bigger? Do you think people will be more receptive? How do you think things will go in like a future simulation?
Yeah, no, that's a great question. So I do think the easier part, I think, is just on the technical side. Yeah. So first of all, like it's really, it's almost too fast. It is remarkable if you think about it that in like January of 2020 or December of 2019, it was like, what's happening? All these people were dying. Yeah. And then really quickly, like within weeks, it was like, oh, it's the SARS-CoV-2 virus. Here's the entire sequence of the entire virus. Right? Think about that. Yeah. Like plague, like just destroyed like whole countries for centuries. Right? And we didn't even know it existed. Yeah. But within like 2 weeks, we had the entire genome of this virus. And then like, I can't remember the exact time. Was it 6 months later, 9 months later? There's a vaccine. That's crazy.
Wild.
Crazy wild. And I think that'll pick up, like they're getting just better and better at that, right? The technical side of it, I think it depends. Depends on, some things are more easier to address with vaccines than others, right? Like we don't know if it's the zombie apocalypse. I don't know if there's going to be a vaccine against zombieism, right? But I think the technical side will go really fast, and then what we learned, right? It's like, and then you're like maybe halfway done.
Do you think
halfway done?
You think we need like 3 more global pandemics where they get the vaccine super fast, so people can trust it?
Well, I'd like to think that we can work on the trust piece without having to go through 3 more pandemics and lose like 15 million people to it, right? Like hopefully we can, through some of the stuff we learn, through some of the work we do with groups like Mass Seal and other, right? There's SEAL groups across the country. We're not the only one. Like that's what we want to think about. Like, how do you do these communications to build trust? And we know, well, you have to act trustworthy. It's not just building trust, right? But what does that look like? And how do we do that with the community so the next time around, right? Like maybe it goes a little bit better. And I don't, there's also people doing research about the impact of social media on all this, right? Because that makes it super complicated. Like the misinformation piece and the social media piece are 2 sides of the same coin.
You think if we like hit an EMP and like there was no social media, like people would be more receptive to?
Well, I think it'd be harder if we didn't have social media. It'd be a lot harder to spread the disinformation. Not impossible, right? Misinformation was not invented with Twitter or with TikTok. Right. But there's been misinformation forever. But it's a heck of a lot harder to spread it around to every single person in the world and feed it to them over and over and over and over again in different formats and without social media. So that one's really hard, right? Because that whole idea of like the open nature of social media, right? There's goodness about this, right? The democratizing 100%. Nature of social media, the fact that it's an open forum for expression are all really important. And it can sometimes just be a miserably dirty cesspool of misinformation 100%. And cynical bad actors just trying to hurt people for fun.
Hey, come on. Trying to draw out emotions.
Right, yeah, for what? Like literally, right? Like some of the misinformation out there, some of it is strategic. It might be evil, but it's strategic. Like we want to mess with the government. We want to tear down this or that. But some of it really just feels totally nihilistic, anarchic. Like I just like to stir up crap and hurt people.
Right. Have there been any exciting discoveries or breakthroughs that you've been involved in or that you witnessed?
Sure. Well, so, I think we all witnessed the discovery of the COVID vaccine. And actually, like, as an ID doctor, I was involved in some of that, not directly at all. Right. I'm close enough to it that I felt like I was in some way involved, which was exciting. And then in terms of my own science, I think, so we do policy work. So for us, a discovery is influencing a policy or understanding why something's working or not working. So, and we did I mentioned we do a lot of work around drug use, and a big thing that goes around, one common infection for people who use drugs is hepatitis C virus, which is a virus that infects your liver. And it's one of those things that you probably don't even know you have it until one day you start having trouble. Because your liver is quiet and you don't really realize it's there, but actually your liver is really important. You can't live without a liver. And it does many, 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 many things. It detoxifies your blood. It makes certain types of proteins. It helps with digestion. It does many things. And if you get hepatitis C and it sits there for 10 or 20 years, it starts to scar up your liver. And then eventually you get what's called cirrhosis, which is scarring of the liver. And then your liver starts not working.
Ooh.
And then you start having a lot of problems. Your skin can turn yellow. Your eyes turn yellow. You start swelling up in your belly and in your legs. You can bleed, and eventually you die. So that's the virus. But there's a test for the virus, and now actually there's great treatments. So anyone who's listening to this who has hepatitis C, there's really good treatments now. You take these pills once a day for 8 weeks, gone. 98% of people cured. No problem. Yeah, so that's cool too, right? This is a disease. That's another thing that I witnessed in my career. This disease, which when I started, I was talking about this stuff at the syringe service program, in New York and in Argentina, and there really wasn't a cure. There were some medicines that sort of worked for some people, but it was very difficult to tell a person, oh, we have a cure for you. It was more about trying to manage it and hopefully slow it down, hopefully. And then these medicines have been invented. Again, it's the same technologies that invented the HIV medicines that were originally funded by NIH. They invented these medicines to stop hepatitis C, and they work amazingly well. You take these medicines for 8 weeks, and there's almost no side effects, and it cures almost everybody, right? So we started doing work to say, well, if we can cure this, shouldn't we be doing more work to test for it? And so we did a bunch of research over the course of almost 10 years, really. A whole bunch of studies in a row showing that this would be, if we started testing all adults, right, for hepatitis C at least once in their life,
Yes.
right, it would save all these years of life and prevent all these cases of liver cancer, and it would be a good use of the, and eventually they actually changed the guidance. And if you look, when they did it, they cited a lot of our work as part of the evidence base to help them do that. So for us, that's a huge, that's the goal, right? It was we set out on this path. It took several years and a lot of work, right? But we just were chipping away at it, publishing. And then actually it did it. So that's kind of, that was exciting.
So wait, sorry. If somebody's watching this right now and they have hepatitis C,
Sure.
what could they do to access the medicine that you were just talking about?
So first of all, if you wonder if you've never had the hepatitis C test, you should get tested.
Okay.
Right? That's the guidance now, that all people should be tested at least once.
Primary care?
Yep, primary care.
Okay.
So primary care for testing. Also, actually, depending on what services you access, there's plenty of places in the community that are offering testing for hepatitis C. Ooh. They tend to be outside of primary care. The testing tends to go out at places where people at risk often seek care. So it's at substance use treatment programs and programs like that. If you're in general, though, most people get it at primary care.
Okay.
And then the treatment can be done in primary care, right? It used to be this really subspecialized thing, and there still are specialized liver doctors, but it doesn't need to be a liver doctor who treats your hepatitis C. It can be it can even be a pharmacist who treats your hepatitis C.
And
with
that's
supervision
actually
of a doctor.
transmitted, right? Or
Hepatitis C is actually transmitted. It is blood to blood, so in that sense, and so is HIV. So it seems like it would be a sexually transmitted infection, but actually, it turns out for most people, it's transmitted either because you had a blood transfusion a long time ago, like you were born, say, 1945 to 1965, and you got a blood transfusion, like maybe because you had a surgery or you had a baby in your 20s and needed a transfusion then, and they didn't have the test, and so actually you could have gotten it from a blood transfusion if you're of that age group. These days, there's no hepatitis C in the blood supply. Sorry, I should have said that. I don't want to imply that could still happen. That got fixed, right? That's old.
Okay.
Blood supply is safe. When people get it today, it's from injection drug use. Almost all of it is injection drug use. You can also get it from getting a tattoo. If you're getting a tattoo not at a legit tattoo parlor and there's unsterile equipment, you can definitely get hepatitis C from that. But just on an epidemiologic basis, there's way more people getting hepatitis C from injecting drugs than from sketchy tattoos. But you can, right? And so, so that's how you get it. You can, it's not really actually very easily transmitted through sex, with one exception. If you are a man who has sex with men, there is actually some more sexual transmission in that group. Part of it's related to the fact that some people have HIV, and those two things work together. But for the most part, it's not a sexually transmitted infection.
So we were talking to one of the doctors from MACL last time, and we were talking about there's a specific group that can get cured from HIV.
Oh.
You know what I mean?
Yeah, yeah,
it's
yeah,
only
yeah.
happened to like one out of
Oh
every.
yeah.
But
So there's
Like
like
controlled
yes.
something.
But that's you got to be
It's-
careful there because it's kind of a proof of concept. It's not like there's a cure for HIV that's
Yeah.
floating around out there.
I was wondering, like, as a specialist in this field, what are some things that you have faith in, like that there will be a cure for, and like things that like maybe it just won't happen, like maybe like, what are some common things like herpes or
Tuberculosis.
Yeah, well, so tuberculosis, like there is a cure for tuberculosis. It's just a hard one, and it doesn't always because there's a lot of you take antibiotics for tuberculosis,
Okay.
but you have to take a bunch of them, 4, sometimes even 6, and you got to take them for a long time, like 6 months, a year. It just depends. And there's beginning to be more and more resistant versions of tuberculosis that don't respond very well to the antibiotics. So we definitely need more cures for tuberculosis. I think another huge one is actually hepatitis B virus. We talked about hepatitis C virus. So like there's all these different hepatitis viruses. Like
is
literally,
B worse?
they're not worse, they're different. Like so what they all have in common is they infect your liver. Like so HEPA is the like Greek medical term for liver and itis is just inflammation. So right where they are first naming these viruses, what we knew was like these are viruses and they infect your liver, so they must be similar. They're all hepatitis, right? A, B, C, D, E, F, G. I mean, they go all the way out. But it turns out actually they all infect your liver, but it's sort of like dogs are pets and cats are pets, but they're not the same thing, right? They're even both mammals, but they're not the same thing. And same thing, like hepatitis B is very different than hepatitis C. There's a vaccine for hepatitis B, but globally there is a lot of hepatitis B in the world, a lot, and a lot of it people don't know they have it, and a lot of times it's spread actually at birth from mother to child, and then it like hides out for a long time, and then it can cause liver cancer. It's bad and so it's a leading cause of liver cancer in the world, and so and it's hard to cure right now. It's very difficult to cure. I guess not impossible is too strong, but very difficult. And generally, when you put someone on treatment for hepatitis B, you're not trying to cure it per se. You're just trying to chill it out so it stops causing damage. But those same companies that made the hepatitis C meds are now working on hepatitis B meds. And I'm super hopeful that that's coming. So that's, a lot of the big things for infectious diseases are global health questions, right? Because the burden of death from infectious diseases is really high globally. And well, I was going to say it's less high in the United States, except that actually, if you look back, COVID started showing up on like top causes of death in America. That's an infectious disease. That was striking to me. Like all this talk about, COVID, it's just the flu. I was like, guys, like look
Deeper than that.
Just look at the causes of death. Like, just watch the causes of death in America. And it's like heart disease, lung cancer, colon cancer, breast cancer, prostate cancer, over and over and over. And then all of a sudden, it's like COVID. It's like, this thing is a leading cause of death in our country. Like, right? Like, when's the last time you saw that happen? It's obviously different, right? Like, this is a big deal. So, thankfully, changing now, right? But COVID did show up as a leading cause of death in America.
Okay. What's the most unusual or surprising case of infectious diseases that like shocked you?
Yeah, well, so if you do infectious diseases, you see interesting stuff.
Yeah,
for
I'll bet.
sure. And again, I already talked about this. A lot of it sort of intersects or overlaps with equity and global justice, right? So we see, right, there's a migrant crisis, and right, and there's folks showing up in a lot of ways, and there are people who are walking here from Guatemala.
Walking on their 2 feet?
Yeah, like a lot. I mean, that's a path. Like there are folks who are walking from South America all the way to North America, and then often their last bit might be on a plane to Boston, right, or something like that. But like plenty of folks that have walked through all of Central America, and you can imagine, right, and not in good conditions, and are exposed to a lot of things, and so you start to see that, and it is like. Well, first of all, you got to remember, like, at Boston Medical Center, if, last year we diagnosed and took care of a patient who had leprosy.
Oh, what?
So leprosy is still a thing, right?
What?
Like you think of it as being like,
That's kind of crazy.
but you have to remember, like, it's not common here, right? So when we go down and look at the slides, under the microscope and see leprosy bacteria, and we're like, whoa, that, from us, like there's a medical expression of zebra, right? Like versus a horse, right? Most things are horses, but occasionally there's a zebra. So for us, that feels like zebra, right?
Right.
But it's not. You have to remind yourself, it's just because you're working here where there's less, right? There's more public health, there's less exposure, and there's more resources. But like diseases that are zebras in America are not zebras in most of the world. But we do. So we've taken care of folks with leprosy. It's not now because Mpox is a thing, right? And there's an epidemic and we're all talking about it. But when it came, it was like, what is this? Right? Like, this is a zebra. We've seen, so you do see interesting things like that. Malaria, like interesting infections that are generally global health, like imported from global environment and often resource-limited settings. Because we've been talking a lot about justice and equity in our own community, which is real, right? We could zoom it out to global justice and equity, right? And there's a whole other dimension to that, right? Who has resources and who doesn't.
How could we get more resources to the people that are come over here walking, taking the plane, interacting with other people? Should we go into the churches and offer resources and services? Would that even be supported by the NIH? Because vaccines cost money.
Yeah.
Health costs.
Well, so what the NIH would support, like we talked at the beginning, the difference between the agencies. So the type of work that the NIH would be eager to fund would be to say, something along the lines of there's a migrant, right? There is a migrant demographic in crisis, and people are coming with a lot of unmet healthcare needs. And so we are designing an intervention that we're going to go into churches, or we're going to go whatever we think is the right place to try to offer these things, right? And then we're going to measure how it goes, right? Do they do better? Do folks get a doctor? Can we show that in some way their health improves? That's the type of work that the NIH would fund. And then if you were saying like, we have this thing that works, what we need to do to get services to people is whatever, but what we need to do is scale that out. That's the type of work that departments of public health and the CDC would fund. So I don't know what the answer is, but that's an interesting idea working, right? We're trying to think about that with Mass Seal.
Right.
And that is like those communities are really tight, often, I don't want to generalize, but often super tight. For better and worse, like if you can crack in, right, there's like this like very powerful community with like clear lines of communication to try to work with, and they're also super marginalized and at risk and understandably hiding. And as much as I want to feel like I have good intentions, right, and I know that my goal here is to help with health, like I'm not going to be able to just walk into the middle of that group and be accepted. Like it takes a lot of work to try to figure out how to do that and 100%. Build trust.
What about if you were transported in time to the Black Plague? You think you could stop it?
I was obsessed with the Black Plague, by the way.
That's kind of a cool question. Could we stop it? If we just showed up now, could we stop it? We might have some luck.
What if like the government was like, all right, we're building a team. You guys
would go back in time and stop the plague.
So cool.
Like we might have some luck because at least we know what causes it and why it was being spread. Right? It was from the bacteria on fleas that were on mice and things like and rats. Right? That's the Pied Piper. Like why they would like blow your whistle to get all the rats to follow you. That's a plague thing.
Oh my goodness.
So like that idea, like I think we know enough about the public health and prevention that perhaps, although man, I don't know, because they've got a heck of a rat problem in Boston right now. Right? So it's not like we don't really know how to get rid of the rats even now. Yeah, right. Seriously,
what
I know.
Would you tell
they're
people?
Scary.
What would you tell people? Like we gotta, to stop this plague. What do we gotta do?
It's about like sanitation and sewage and things like that,
like,
and
take a shower.
Yeah, right. But this is in the Middle Ages, right? They didn't have showers. Like it wasn't that easy. But yeah, it's about. That was spread from these fleas on rats and things like that. And so a lot of it is about like sanitation, sewage. And you see that now, like in refugee camps and things like that, when that basic sanitation infrastructure breaks down, there's cholera outbreaks, there's rampant hepatitis outbreaks. Like that's what killed so many people in Haiti. They had that earthquake, right? They had a huge earthquake and all the infrastructure was disrupted. And then, this is a sad story, the UN came with absolutely outstanding intention to provide services, and unfortunately, the people who came brought some cholera, and then it just epidemic, like horrendous, because the basic sanitation broke down. So that is some of what makes modern times look different than the medieval time is like sewage and sanitation and just basic things like that.
Do you have a dream team? Like if you had to go back in time, who do you take to stop the Black Plague?
Well, I guess I have to bring Tony Fauci, right? Like,
Come on down, Tony. Dr. Fauci.
I don't know. I'd bring a lot of my colleagues who I work with today, though, because they are really great.
Yeah.
Thou shalt wash your hands.
Yeah.
Yeah, I mean, seriously.
So let's wrap this conversation up. I have one last question for you. It's kind of fun. If you were a tool or implement, which one would you be? Like a surgical tool or whatever tool you be using.
Okay. So, all right. So surgeons have this thing called the cauterizer. I'm not a surgeon, right?
Okay.
But right, when you're in medical school, you always have to do everything, right? So I
Right.
have stood there and watched surgeries.
Okay.
It's been a little while. Actually, sometimes I'll say this, even these days, sometimes I will go down, like if a patient has a heart valve infection, right? Sometimes we don't go down, like those are long surgeries, but sometimes we'll go down to the surgery to see what's happening. And it is very interesting. Like it's one thing to talk about someone's heart valve infection,
Right.
and then the surgeons actually take it out and you look at this thing and you can see the damage. And so occasionally I'll do that. But back in the day when I was sitting there doing my stuff, so they have this thing called the cauterizer, which is this little, it's like a tool that's like a long piece of metal and it burns things, right? So if there's like a blood vessel that's bleeding, you go and it cauterizes it and it stops the bleeding.
Yeah,
Is
yeah.
that thing where like if you cut off your thing, you take like an iron. And
Yeah.
Same idea.
That happened to me actually last week. I got a little, it was actually pretty big. Went to the dermatologist and got the skin tag taken off and got it cauterized.
Right. And then it bleeds and,
it
then it
bleeds,
stops.
yeah.
Yeah, exactly. So that thing is cool, right? They use it all the time.
Okay.
But then once I was in a surgery and like the surgeon called for this thing called the argon laser. I'd never heard of this. Exactly. So they take this thing out. It's a little bigger than the cauterizer for sure, but it looks roughly the same. But then he pressed the button and it was like this beam of light, like Thor's hammer or something. It was like this huge beam of light that then stopped this larger thing. But so I think I'd be the argon
But it
laser.
burns, like, right?
Yeah. It was doing sort of a similar thing, but over a larger area.
It's kind of crazy that we're talking about infectious diseases and burning. That's like the slang, right? If you burn somebody.
Oh yeah, right. Well, that's like surgery. We don't burn anything in infectious diseases. That's what they used to do, like in the medieval era, right? Like, oh, but we're gonna burn that out of you. No, we've evolved beyond that. There are no therapies that I prescribe or supervise or manage that involve burning. It's all medications.
Is there anything else that people should know about the NIH, about community engagement?
Or resources.
Right, and resources that they maybe even have access to that they don't even know that they have?
Sure. So please check us. So we want to provide resources to our community. Mass Seal has, and we've developed a lot of resources based on public health needs over the last 3 years, and we're eager to keep doing that as new needs arise. So I always encourage folks to check us out online.
Like what specific things though?
So we have health information about diabetes. We have health information about Mpox. We have health information, of course, about COVID. Trying to think off the top of my head. I think we have some health information about partner violence. And we're not closed for business. Like we're open to, thinking about what resources are needed, why and where, and how could we help.
Are you guys going to get into mental health at all?
Definitely we want to be involved in mental health. It's been really, I sort of said, because it's such a burden. I mean, on me personally, because there's mental health things in my family, and on our society, it's just striking to me how much mental health. There's really, if mental health was infectious and we could spread it to each other, we'd be in lockdown.
Yeah,
right.
We actually did street interviews and
That's
mental
powerful.
health came up all the time. People like,
The main
what do you guys
thing
want to
that
talk
came
about
up.
for mental health.
Yeah, no, I know. I'm like, it's upsetting to me because, like, personally, I feel that. Like, there's several people I love who've had major mental health struggles in the last couple of years.
Yeah.
And there's also colleagues who I love, like our family members, but care about who have struggled. I've seen team members have struggle and need to take time off.
Yep.
So it's real. It really
yes,
is.
100%.
And some of it's COVID for sure still. But I think, it's more than that. Some of it's probably social media and the fact that we all just live in a fishbowl at all times. And I don't know, right? I think if I wish I knew, I'd try to fix it.
Right.
But I think, yes, we very much want to be supportive on mental health. I think we could develop, and we have access also to other resources with it, right? Like, I'm a doctor. We work at BMC. There's several doctors and various different types of healthcare professionals on our team. So it's not as if we necessarily have at our fingertips the treatment for you today for your mental health problem.
Right.
But what we do have is knowledge of how this system works and colleagues there who we can call and say, there's this problem, right? And try to broker relationships, try to think about how we could get involved, we also have a lot of experience writing grants and thinking about well, if you have that idea, how could we get that funded? Right. Not that we're going to get it funded, we want to get you funded.
Right.
So things like that, right, is definitely the type of work that we want to be doing. So we're at massseal.org is the website. And then you would mention about the NIH. Like, I hope people come out of this recognizing that actually, like, you may not have known it, or you might have even been skeptical of it because of everything that happened with COVID.
Right.
But actually, like, I hope you can hear it in my voice. Like, the NIH is there for you. Like, it wants to be doing the work to improve your health and the health of the people you care about. And I'm not trying to say it hasn't made mistakes. Don't get me wrong. Right. But I wouldn't throw away the whole thing. Like, don't throw out that baby with the bathwater. Because, like, you should go check it out. Like, right, some of the stuff at the NIH is going to be super duper hardcore scientific and not speak to you. But I think you'll see that even those parts of it, right, it's even the most most basic science, like nitty gritty, like, chemistry stuff.
Yeah.
Why people are doing it is because they see its potential to help and improve health and improve well-being, right? And maybe it's many steps away. Maybe it's going to take another 20 years to actually get to the medication from the chemistry. But the reason we're doing it and the reason the NIH is there is it's not just because it's interesting, right? It really is motivated by trying to improve health and make your life better.
That makes sense.
Yeah, that definitely makes sense. If anybody wants to contact you, could they do it directly? Do you have an assistant? If somebody's watching this and they're like, dang, I really need to talk to him, how could they access you?
Yeah, people can email me. I have my professional email. It's my name. It's benjamin.linas, which is L-I-N.
Can you spell it for the people?
Yeah, so Benjamin, normal way, BenJamin dot Linas. That's a little weird. Linas at bmc.org. And I'm available, and then, right, depending, maybe I'll be able to help. Maybe I'll put you in touch, right? But if people have a question or something about our work, by all means, I'm definitely love to talk to you.
Thank you so much. I know I don't have any questions. I feel like I need to digest all of this because I love health. I think that health should be one of those things that should be a top consideration of every people's mind, because you can spread things skin to skin, minding your business, accidentally swipe across somebody and get a little something. Seriously, right? Awesome. Like, I'm excited that we're doing this because we live in Boston. We do have a lot of people coming over. I didn't know that they were actually walking over. That's absolutely fascinating. So I hope that Show and Tell Boston could be a resource for you. I hope that Dr. Ben Linas could be a resource for you. Mass Seal, all about community engagement. We are a community. That's what we're all about at Show and Tell. And I hope that anybody watching this knows that they have an open door to us, to Dr. Benjamin, to Mass Seal, and to advocate and prioritize your health. So you can find me at TheRealKriket Smith at Instagram. How can they find you?
No, just Show and Tell.
At SHOWANTELLBOSTON. And thank you so very much.
Yeah, no, thank you guys for having me. It's really been fun talking about our work, talking about it all day. And I just, we're talking about health, and I do think, like, our vision for this is if we can partner with the community and with Mass Seal and other groups like that to think about all of our personal health, it's also going to help heal our community, right? Like, work in health, right? It's medical health, and it's sort of our social community, spiritual health, and those two things can go together if it's through the work that we're doing, right? It's like, yeah, we'll improve diabetes, but the process of doing that, I hope, I think, can really heal our communities as well.
That's right.
100%.
I agree. All right, people, it is a wrap. Thank you guys for watching.